We are nearly right on time. Final paper is a virtual presentation, Operative Autonomy, Assessing Resident Impact on Surgical Outcomes in below the knee amputations. This is from also our colleagues at VCU.
Hello, everyone. My name is Alex Simmons, and I'm a current PGY3 General Surgery resident at Virginia Commonwealth University Medical Center. Thank you to the program committee for the honor of presenting our work entitled Operative Autonomy, Assessing Resident Impact on Surgical Outcomes in Below-the-Knee Amputation. This presentation does not necessarily represent the views of the Veterans Affairs healthcare system, nor the United States government. Additionally, none of the authors have any relevant financial disclosures. In 2003, the ACGME instituted duty hour restrictions limiting trainees to an average of 80 hours per week, averaged over 4 weeks. This change in duty hours has had an unclear impact on resident autonomy. Below-the-knee amputations, or BKAs, are a common surgical procedure undertaken by general surgery trainees with a reasonable expectation of mastery by the completion of their training. BKAs are considered to be a core part of the ACGME required 50 vascular cases in order to complete a general surgery residency. Examining some of the previous work on this subject notes that program directors feel that graduating residents obtain near independence in only 27.1% of all procedures and only 1/3 of all core American Board of Surgery procedures by graduation. More than 80% of graduating general surgery chief residents are seeking additional fellowship training, possibly due to the loss of autonomy. Nearly half of all fellowship directors felt that graduating fellows would be unable to perform 30 minutes of a major operation independently. We sought to use the Veterans Affairs Surgical Quality Improvement Program, or VASQIP database, to compare surgical outcomes between below-the-knee amputations performed by residents independently versus those as with an attending surgeon scrubbed. After IRB approval, we examined VASQIP records from 2000 to 2020 using CPT codes for below-the-knee amputations. We excluded all cases that were defined as emergent, traumatic, being undertaken by staff surgeon only, and those that did not define the level of resident involvement. Records within case match based off of gender, diabetes, renal failure, smoking status, steroid usage, congestive heart failure, COPD, and open wound infection at the time of amputation. 2 cohorts were then defined: attending surgeons scrubbed during the case and those that were undertaken independently by resident surgeons. 1,344 cases were established in each cohort. No statistical differences existed between the 2 cohorts in preoperative characteristics, and no difference existed in ASA score between the 2 groups. Notably, cases in which the attending was documented as being scrubbed were more likely to have a do not resuscitate order, as well as were more likely to have wounds classified as infected. In examining 30-day postoperative outcomes, resident independent cases stayed on average 3 days longer, with slightly higher rates of deep wound infection and intraoperative bleeding requiring more than 4 units to be transfused. No other measured outcomes within 30 days were noted to be statistically different between the 2 groups. Looking at trends over the 20 years examined, found a significant decline in documented resident independent cases. The blue line above represents cases in which the attending was scrubbed during the case, and the red line represents cases in which the attending was not scrubbed. Note that this is in fact a log scale, which was required to visualize the rapid decline in resident independent operating over the time examined. Notably, this study is retrospective in nature, as well as a database study, which can be associated with a lack of granularity and some documentation bias. From this work and from the work of others, it's clear that there has been a rapid and dramatic paradigm shift in the training of general surgery residents as pertains to the loss of autonomy. Our study noted a 95% decline in resident independent operating over the 20 years examined. In conflict with some other studies, we were able to demonstrate a similar safety profile between resident independent cases and attending presence during the operating room case and below-the-knee amputations. In conclusion, rates of resident independent below-the-knee amputation have declined rapidly since duty hour changes were implemented in 2003. Residents appear to be capable of performing below-the-knee amputation with similar safety and complication rates as when the attending surgeon is scrubbed. Further work needs to be done examining the relationship between resident autonomy and the impact on independent practice readiness. These are my sources. Thank you very much for your time. I'm happy to take any questions that you might have.
Thanks, Dr. Simmons. This paper is open for discussion. I'm a little worried in the room. There's enough of my prior trainees that probably have contributed to some of your data there. So go ahead, Dr. Humphreys.
Misty Humphreys from UC Davis. I actually think this is really important because I think that the trainees constantly want to feel that they're getting more and more autonomy. And with a lot of the quality improvement that we're doing, sometimes we don't feel that we can give it because we're so highly scrutinized on every single thing. So I really encourage you to publish this because I think seeing that there are no different, in fact, the attendings were slower. I always think the residents are taking forever, and apparently they're not. I thought there was just really good information here that helps when we go to our operative, our operating rooms and we say, no, it's fine. And also with the VSB and ASB trying to develop trustable activities for residents, I think this is really important. So my main question, though, is do you have this kind of data for other types of cases that you're looking at?
Well, thank you so much for that question. I think those were some excellent points that you made about competing interests in the operating room and the EPAs that you mentioned as well. We actually do have data for other surgeries. I've examined cholecystectomies, appendectomies, as well as some hernias, and have found nearly identical findings with graphs that look basically identical to the one here for below the knee amputations. So it's a problem that spans all of general surgery residency, not just this particular vascular case.
Congratulations.
Thank you.
Dr. Tiagi.
Hi, Sam Tiagi, Lexington, Kentucky. Just had two questions. One, you showed your patient cohorts were different for the surgeon being scrubbed and not being scrubbed. Did you case match those in your results or not? I don't know if I got that out of there. And the other thing is I operate also at a VA, and so there's different VAs may or may not have different policies. I'm not sure because I only work at one, but at our VA, unless there's it's a PGY-5, general surgery chief, resident scrubbed, or a fellow, the attending has to be in the room or present for that. So are there different policies at different VAs, and has that changed? Because you showed a rapid decline, which perhaps could be a change in policy at the VAs as well. So.
Yeah, those are great questions. Initially, whenever we examined this data, there was actually very significant differences in the preoperative comorbidities between the two groups. The resident independent cases were significantly sicker in basically every single measure that we had. So case matching those intended to sort of create fair groups. So we did case match on basically every preoperative comorbidity that VASQUIP provides us with. As far as policy goes, I'm not aware of any national policy. I think that those things are most likely local, but I'm not positive on that.
I can comment. I'm 1 day a week at the VA, and they grade me if, how involved I am. Like I get a score of an A, B, or C, and if I'm not scrubbed, I get a C. So I try to shoot for a C every time. But one more question I have is, did you account for vascular residents and fellows in this model? Because I saw where the drop-off was. Could it be explained by the fact that you have more vascular residents now involved, and perhaps general surgery residents are losing autonomy because of that?
That's a fantastic question. To my knowledge, the VASQUIP database codes all trainees the same way. So I don't think that the vascular independent residencies should affect this in any way. We did try to do an analysis based off of the PGY level of the resident. The problem, the way VASQUIP asks the question is list the PGY level of the primary surgeon. So even if the resident did the whole case, but the record shows the attending's name, they'll code that as a PGY 10. So it colors that variable in a way that we didn't feel like it was usable in our final data.
Well, we're going to end on a high note because you said PGY 10 and Dr. Lee is very happy.
PGY 10, yeah.
He's PGY 10. Yeah. All right, guys, with that, I think.
I'd welcome everyone to stay for the Boston Scientific session. Appreciate their support over the years. That will be a 30-minute session, so everybody can refresh their drink and then come on back. And then would welcome everyone to go back to their room to grab their guests and their family to come down for the welcome reception that everyone is welcome to this evening from 6:30 to 8. This concludes scientific session number
I'm
one.
going to put in one plate for Dr. Rajani. He'll be very happy. But make sure you guys get your abstracts into papers. And I think this year has been a record as to the number of papers you guys have submitted before the meeting. So I think that's fantastic. And even rapid fire papers. I think last year the acceptance rate was 100%. So I encourage everybody to submit them to the annals. And Dr. Rajani got your back.
Thanks, everyone.
Thank you.